Okay, welcome back. Primary immunodeficiency. This is the next section in Chapter 2 that we want to cover. And the first disorder that we're going to talk about is DiGeorge syndrome, very high yield. This is a developmental failure of the third and fourth pharyngeal pouch. So this really goes back to embryology, and it's a mechanism by which they can test you on embryology. And it's essentially associated, first important point is that it's associated with a 22q11 microdeletion, and that's high yield to be aware of. So failure to form the third and fourth pharyngeal pouch, which is basically associated with a 22q11 microdeletion. Now, important to know that these patients are going to present with classic findings of the lack of the structures that are derived from the third and fourth pharyngeal pouch. For example, the thymus is derived from that region. And so if there is a lack of a thymus, there'll be a T-cell deficiency. Now, that T-cell deficiency occurs because remember that T lymphocytes or T-cells are actually born from the bone marrow, but then go to the thymus to become educated and to eventually become CD4 positive or CD8 positive T-cells. And so if there is no thymus, there will be a T-cell deficiency. And so that's one important finding in these patients. Of course, if there's a T-cell deficiency, the patients will have problems fighting viruses, and they'll have problems fighting fungal infections as well. Another important finding in these patients will be hypocalcemia. Why? Because the parathyroids are normally developed in the third and fourth pharyngeal pouch. So if there's a lack of parathyroids, there'll be a problem with maintaining adequate levels of calcium within the serum, hence hypocalcemia. And then finally, within that region, from the third and fourth pharyngeal pouch, important things that also develop include the great vessels, areas of the lower face, the heart, the anterior aspect of the heart, the superior aspect of the heart, etc. So all of this kind of makes sense if you understand a little bit of embryology. The next disorder is called SCID. This is severe combined immunodeficiency. And basically the idea here is that the patients get defective both cell-mediated, i.e. T cell, and humoral, i.e. B cells, because they produce antibodies, which is called humoral immunity. So in SCID, you get defective cell-mediated and humoral immunity. Now, what are the etiologies? There's three major etiologies. Number one, cytokine receptor defects. Now, you know, and we've already told you to make it very clear that the CD4 positive T cell, it is a helper T cell, and it helps the B cells to become mature and to fight infection, and it helps the CD8 positive T cells to also become activated to fight infection. So cytokines, which are produced by the helper T cells, you can see how important they are because it's the cytokines that drive the maturation of the entire chronic inflammatory state. So if there are defects in cytokine receptors, patients can develop severe combined immunodeficiency. Very high yield for exam, and I would say probably the most high yield on this slide, is a adenosine deaminase deficiency. Adenosine deaminase is a enzyme that's necessary for deamination of adenosine and deoxyadenosine. This goes back to a little bit of biochemistry and salvage pathways. But basically, what you need to know is that adenosine deaminase deaminates adenosine and deoxyadenosine, and that the buildup of adenosine and deoxyadenosine within lymphocytes is actually toxic to lymphocytes. And so patients who have adenosine deaminase deficiency can get severe combined immunodeficiency, and this becomes very high yield because it goes back to biochemistry. And of all of these etiologies, for me, this is the highest yield. And the third mechanism by which we can get a severe combined immunodeficiency would be an MHC class 2 deficiency. Now, think about this for a second. MHC class 2 is recognized by which type of T cell? It is recognized by the CD4 positive T cell. And the CD4 positive T cell is essential because it helps CD8 positive T cells and it helps B cells. And so if the CD4 positive T cell cannot get activated because MHC class 2 is missing, once MHC class 2 is missing, we're going to get defective function of B cells, defective function of T cells. And so I think that clearly explains why these patients would have a mixed humoral and cell-mediated deficiency. All right, so these are some of the key etiologies to be aware of. Now, what are the characteristics? So these patients don't have T cells, so they're going to get fungal and viral infections. And these patients don't have B cells, so they're going to get bacterial and protozoal infections. And there's going to be an increased risk for opportunistic infections. They're sort of like an AIDS patient, but much worse. So they can get opportunistic infections. And you want to be aware of giving these patients live vaccines because they essentially have no immune system. How do we treat? These patients go in sterile isolation. They're also called the bubble baby. And you give them a stem cell transplant. Now, why does a stem cell transplant work? Because if you put stem cells in their bone marrow that are normal, let's say you take stem cells from another patient and put them into this patient's bone marrow, those stem cells, the hematopoietic stem cell, so hematopoietic stem cell here, has the ability to generate both B and T cells. And so the patient will then generate normal B and T cells and will then obviously be able to develop the immune response necessary to be able to fight off infections. So the sort of the temporary measure is isolation, sterile isolation, a quote unquote bubble baby, and the final treatment is a stem cell transplant. Another immunodeficiency to be aware of is X-linked agammaglobulinemia. Let's look at the name. A means without, gamma globulin refers to immunoglobulin, and where? In the blood. So these patients are lacking immunoglobulin within the blood, and it's X-linked. So this is due to a lack of immunoglobulin. It's due to a disordered B-cell maturation so that naive B cells cannot become plasma cells. Remember that it's the plasma cells that actually have the ability to secrete immunoglobulin into the blood. And so naive B cells cannot mature to plasma cells and hence cannot drop immunoglobulin into the blood. And so that's X-linked agammaglobulinemia. And I would say that the highlight here is that the mutation is a tyrosine kinase mutation. In particular, it's called Bruton tyrosine kinase, also called BTK. So Bruton tyrosine kinase is a tyrosine kinase that is tyrosine kinases are signaling molecules. So it is a signaling molecule that is necessary for a B cell to become a plasma cell. When it's mutated, and it's usually X-linked, that results in this particular disease called X-linked agammaglobulinemia. Now, how will these patients present? Well, they're going to get bacterial infections, enterovirus infections, and giardia. I would burn this in my brain. When I'm lacking immunoglobulins, I'm going to get three types of infections. Bacteria, because I don't have the ability to opsonize properly because I don't produce IgG. Enterovirus and giardia. Bacteria, enterovirus, and giardia. And enterovirus basically is a virus that affects the mucosal surface of the GI tract. And remember that IgA protects against mucosal infection of the GI tract, and these patients aren't going to have IgA, so they'll get enterovirus. And giardia is the same thing. It usually produces a GI infection. Mucosal IgA would be protective against it. And so these patients are going to present with these classic findings. Usually it's after 6 months of life. Why after 6 months of life? Because the patient has mom's antibodies floating around prior to that. The antibodies last for a period of time from mom, and so they usually don't present until after 6 months of life. And you have to be careful in these patients. You don't want to give them live vaccines because their immune system is down, and those live vaccines, whereas a normal patient would be able to deal with an attenuated live polio vaccine, these patients certainly would not be able to handle this vaccine, and it would eventually cause complications of that infection within the patient. Another important disease is called common variable immunodeficiency. Now, listen to the name, common variable, i.e., the patient has low immunoglobulin, and this is due to a B cell defect or a helper T cell defect. Why B cells? Because B cells produce immunoglobulin. Why helper T cells? Helper T cells produce IL-4 and IL-5 when the appropriate signal is present. And so both helper T cells and B cells are necessary to properly produce immunoglobulin. Now, again, these patients have low immunoglobulin, so what are they going to get? Bacteria, enterovirus, giardia. That's why I say burn that in your brain. Bacteria, enterovirus, giardia. In addition, these patients are often asymptomatic, and they usually present late in adulthood. And as they continue on with their life, there's an increased risk for autoimmune disease and lymphoma, and that's high yield. An increased risk for both autoimmune disease and lymphoma. Okay, the next disorder is called IgA deficiency, and the idea here is that the patients have a low serum and mucosal IgA. This is the most common immunoglobulin deficiency. And guess what kind of infections they're going to get? Mucosal infections. IgA is on the surface of is on mucosal surfaces, and helps to protect against mucosal infections, especially viral infections. And so these patients will get an increased risk of mucosal infections, especially viral. Now, maybe we could stop here for a second. I can tie in a little bit, do a little bit of circular review. Do you know which GI disease is associated with with IgA deficiency? Otherwise stated, in which GI disease is there a high propensity of patients who have IgA deficiency? The answer is celiac disease, and that's something to be familiar with clinically as well as for examinations. So in celiac disease, one of the associations of celiac disease is IgA deficiency, and we'll talk about that when we do the GI lectures as well. Okay, hyper-IgM syndrome. I actually like this one. This shows up a lot on exams. It's a great way to test a little bit of normal immunology. So what's the idea here? It's characterized by too much IgM. And the key feature here is that the patients have a mutation in the CD40, something to do with CD40 ligand or CD40 receptor. So let's go back and review for a minute. Can we remind ourselves that there were two ways by which B cells get activated? I'm going to wipe this out just to go back and do a little review. There were two ways, as I talked about in the prior lecture, in which B cells can be activated. The first way is for a naive B cell, which basically looks like this and expresses IgM on its surface, correct? And I said that one way for this cell to get activated is that an antigen binds IgM on the surface, and that then results in an IgM secreting plasma cell. And that plasma cell can then produce IgM. So that's one way by which the by which the B cell can be activated. Okay, so bear that in the back of your mind. A second way, I'm going to go back and give you another whiteboard here. A second way by which the B cell can be activated is that the B cell, so let's pretend that this is the B cell, can actually internalize the antigen and present the antigen instead on, let's say that this is MHC class 2, right? So if the B cell presents the antigen on MHC class 2, the CD4 positive T cell will bind that antigen, and that will result in the first stimulus. But remember that there's a second stimulus that occurs, and that is a CD40 stimulus, and that's really what you have to remember. The CD40 is basically expressed by the B cell, and it binds CD40 receptor on the T cell, and it's the binding of CD40 to its receptor that provides the second signal so that the CD4 positive T cell can get activated, CD4 positive T cell, and when the CD4 positive T cell gets activated, it's going to produce IL-4. Remember the two key ones are IL-4 and IL-5. Then IL-4 and IL-5 will basically go back and hit the B cell, allowing the B cell to mature and to undergo class switching, so that eventually that B cell can produce IgA, IgG, and IgE. Okay, with all of that background, now we go back to this disease, which is called hyper-IgM syndrome. It's characterized by an elevated IgM. In this particular disease, the first mechanism of activation of B cell is okay. It's intact. So that what can happen is antigen can bind the B cell, and the B cell can produce IgM. However, the second way of activating B cell, which was dependent on CD40, is mutated. Either CD40 is mutated or the CD40 receptor is mutated, but the problem is that second signal cannot be delivered to the helper T cell. If the second signal cannot be delivered to the helper T cell during B cell activation, then those cytokines, i.e. IL-4 and IL-5, necessary for Ig class switching cannot be produced. So IgA will be low, IgG will be low, and IgE will be low. But IgM will be high. Why is IgM high? Because the very first mechanism of activating the B cells, where they've overproduced IgM, is intact. All right, so that's the way to remember this. Now what's going to happen? Because IgA is low, you're going to get mucosal infections. Because IgG is low, you're going to get recurrent pus-forming infections because IgG is an opsonin. So these are some of the key features and clinical features that would be present in this disorder. Very high yield, okay? Hyper-IgM syndrome. It's very high yield because it allows for examiners to go back and test you on some basic principles of immunology. Okay, and it really goes downhill from here. So Wiskott-Aldrich syndrome, basically you just have to sort of memorize that this is characterized by a triad, and that triad is thrombocytopenia. That's number one. So they get an increased risk of bleeding. They can get petechia on the skin, for example. Petechia on the skin and mucosal membrane bleeding. They get eczema, so they'll get a skin rash. and the patients get recurrent infections, and they can get they have defective both humoral and cellular immunity, so they get a variety of infections. All right, so that's the Wiskott-Aldrich syndrome. This is due to a mutation in the Wiskott-Aldrich syndrome protein. No rocket science. Wiskott-Aldrich syndrome protein, and that is X-linked. Okay. Another another circumstance in which we may find immunodeficiency is where there is complement deficiency. There's really two high yields here. Number one, if a patient is deficient in anything from C5 to C9, so C5, C6, C7, or C8 or C9, there'll be an increased risk of Neisseria infection, and that is high yield. Okay, that's one. And then two, if the patients have a deficiency in something called C1 inhibitor, they will develop edema of skin and mucosal surfaces, and that's called hereditary angioedema. Now, what's the idea here? Remember that C1 is an important activator of complement, and it's an important early protein in the complement pathway, and when it gets activated, it turns on complement. Now, in order to decrease the potential risk of activation of C1, we have something called C1 inhibitor, which helps to sort of control C1 so that it doesn't get activated except when necessary. But if the inhibitor is deficient, we're going to get overactivation of C1. Overactivation of C1 will overactivate complement, and the consequence of overactivation of complement will be vasodilation, increased vascular permeability, and some of the classic findings of acute inflammation, particularly the formation of edema. And to these patients, the consequence is something called hereditary angioedema. The classic finding is edema of the skin and mucosal membranes, especially periorbital. That's classic. And so I threw in a little picture here. This is a little picture in which we see that this child's are edematous, or the skin surrounding the eyes is edematous. And this is a classic image of hereditary angioedema. And that really closes off this particular section of immunodeficiencies. And so we'll go ahead and stop there, give you a little chance to catch up, and then we'll continue on with autoimmune disorders.